So I'm with Greg Solis today, also affectionately known as Gregorio, but his friends call him Greg. And Greg is among our network of advisors and supporters and facilitators within the People Before Patients network, and more newly, the Commons. Greg and I have a lot of conversations often about, as we do with all of our advisors, about the state of healthcare. And Greg brings a different perspective than some of our other advisors who are working more on the coaching side and on the facilitation side. Greg brings more of a kind of designer's perspective. Greg, welcome. Good to see you.
Thank you for having me.
Maybe before we just jump in, just let everyone know a little bit about you. What do you do? Like, what's your
All right, so I'm a multidisciplinary designer. I'm a hands-on designer, and so even though my LinkedIn looks like design leadership, I am the kind of person who's always focused on making. Um, Even when I manage or when I facilitate, I'm always focused on making. I my focus is also on complex systems like mobility, healthcare. Typically, these complex systems come with problems of access, and so that's another lens there. And of course, I'm a research-focused designer. Like I understand also that the aha moments happen in the tension between the fringes and like those like edges. Uh, but impact happens in the mainstream. So I'm trying to like work at both those levels. Um, I call myself a mixed methods uh, researcher. And so that doesn't just mean that I do quantitative and qualitative research, but also I mix it up in the edges between rigor and divergence. So, like trying to be anthropological sometimes, or very intentionally putting up a provocative lens, others to understand, like, where the limits of something might be. And then lastly, like while I call myself a vision-centric designer, I always filter that vision through the lenses of desirability, visibility, and viability. So I do have a strong um, engineering mindset, strong like mindset that considers the mechanics of what I make. So that's a little bit of like the the description that I'm giving when I need to talk about myself. Specializing in healthcare and mobility for the last 7 years.
what would be like a suitable metaphor to describe what you do? Is there one metaphor that you think people could connect to really understand what you do?
I mean, the metaphor that I like to use and is that I fall in love with problems for a living.
Perfect.
That's my metaphor.
I
Yeah.
love it.
Thank you.
The good news is, as someone who works in healthcare, is we tend to run into a lot of problems. So that's probably why you're also attracted in some ways to healthcare.
Indeed, that's actually it. Like, these complex systems are typically made of patched together solutions that often don't function well together and often are under-designed. And so I started my career in entertainment because at the time entertainment was in a massive, moment of transformation, and then have been moving through industries that have traditionally not moved fast, and are at a tipping point in which they need to move fast to continue existing. And so that's where mobility and healthcare have become my focus recently.
Yeah. I the other day we were talking and I was sharing with you an experience that I had in a hospital. I'd been in hospital for a kidney stone, and I shared with you some of the touch points that I had in that hospital setting.
Hmm.
And I got the sense that the hospital wasn't built for me, that it was um, built for a procedure. Like it was built for a very functional purpose.
Mm-hmm.
And there were many instances in that experience where I could feel a certain level of friction.
Mm-hmm.
The friction of being under very intense and bright light all the time, whether someone was interfacing with me or not. So whether I was in a state of active interaction or if I was in a state of rest, there was always the same quality of light. Be like being at home and you're trying to relax and there's always just a glaring light on you. Or having the comfort of my wife present, who was also accompanying me when I was in a state of disorientation from pain, her being asked to leave the room because the room hadn't been designed to accommodate for even a little bit more space to have someone else present.
Mm-hmm.
Showing up in the hospital in a very, very elevated state of pain, which again came with some disorientation, having nowhere in that triage space to lie down, just nowhere that could really accommodate or flexibly accommodate my experience in some way. And you said to me something that I kind of the starting point for our conversation. You said to me that hospitals are engineered; they're not designed.
Mm-hmm.
And I think that we could maybe extend. I'm sure we could probably apply that same logic to other aspects of healthcare, but in this context, we were talking about a hospital. Maybe let's start there. What did you mean when you said hospitals are engineered, they're not designed?
Well, the thing is, we are coming from a time where many advances in modern medicine have come out of the double-blind, peer-reviewed scientific approach that typically focuses on the parts rather than the whole. And that comes from an engineering mindset that historically, because of regulatory complexities, because of technical complexities, leans towards over-engineering the experience. It's important to remember also that hospitals have only recently, just from the turn of the 20th century, have been electrified, and so there's every time a technology is implemented across something. So think about electricity as something that has been patched on top of the hospital experience.
Hmm.
So that there's an immediate excess of that thing in the experience, right? The novelty of electricity brought many advances to medicine, but it's as a direct consequence also created a technical complexity that that was not designed to treat the holistic experience of a person, but rather that was applied to every area of healthcare separately. How might we give a doctor better sight of the operating table? How might we make the hallways of the hospital benefit from that vision being available everywhere? And so, of course, when we pair that with the fact that condition-centric healthcare dehumanizes people, it's actually very easy to see that no one really asked someone, "Hey, how do you feel in this room because of the lighting conditions?" The assumption was that the doctor must see you wherever wherever you are, even if it's the hallway, apparently. And what's important about this condition-centric design is that when I design for healthcare, it's so prevalent that I've actually had to give personhood to the conditions, the instruments, the hospital rooms, because they have such importance in the current experience that documenting how the frictions occur because of their importance, like they are active actors, becomes essential. And so that's actually how blueprinting the healthcare experience needs to reflect how mismatched or how over-engineered and under-designed the experience is.
What's the difference in that? Yeah, and just to clarify, I think when you were saying condition, you're referring specifically to health conditions, right? Like designed with health problems. What's the maybe to help distinguish for people just the fundamental differences between an engineered outlook versus a designed outlook? Like what are just the very clear differences between those two approaches?
Well, I think we were talking about this a little bit. I think not the main difference, but an important difference there is that um, uh, properly done, design yields an unexpected outcome. And basically the like let's figure out what we need to design rather than like let's design this thing. And engineering involves the execution of that outlook. And so let's begin by saying that both are incredibly necessary. I'm not anti-engineering, um, but typically because the engineering is the part that like makes the thing. When complexity requires that we look at what's truly important about an experience, uh, in a scientific environment, typically engineering is prioritized. And that's actually why we find so many things that are under design in our everyday life in many industries, from finance to healthcare. So that's it for me. Like a key difference is exactly that the outcome of of a properly conducted design is meant to be unexpected, and that typically uh, doesn't sit specifically in healthcare. That doesn't sit very well with a profession that is known for wearing a belt and suspenders.
So, yeah, it's interesting because is it a side effect of a kind of scientism? Because when I think of science, I think of a natural curiosity. Um, you think about there would be no science without real curiosity. Um,
That's also something that I think. Well, so if you think of the Industrial Revolution, it's also like being at the core of over engineering and under designing things. Um, the industrialization of things means efficiency, ability to replicate, ability to produce, to mass produce, and so that's another reason why uh, things get under design. We have this industrial approach to everything, including healthcare, and this industrial approach negates that the origin of all science is magic. And so for me, like even before that curiosity, there has to be magic, so that a human is attracted to that magic. And then that curiosity leads to the exploration that over time yields evidence, and then science.
how are
So I
you
think,
how are you using the word magic? Just to clarify, because that word obviously mean a lot of things to different people. I just want to clarify how you're using that word magic.
well, so magic in its purest form, basically something that is fascinating because it's incomprehensible.
Hmm.
Something that like attracts our attention because it's unusual and it's also incomprehensible. And I think that that's the origin of all curiosity. Like curiosity begins when you look at the world and something strikes you as um, escaping your reason, perhaps. So, and again, that's why, like, what for someone should be science, for someone else it can be magic, or if we want to like talk about it in a negative way, woo woo. There's a lot of like uh, angst against woo woo in healthcare, and with reason, because the snake oil salespeople are real, and so we've seen a lot of like anti-scientific thinking during the pandemic, for example, and it's not a coincidence that healthcare is firewalled by regulatory agencies because the other way has caused a lot of harm. And so, of course, healthcare's like main tenet is do no harm, uh, which is also interesting because there's that is probably the biggest enemy of the rapid advance of any science. Like that excessive caution. I'm not saying that the caution is not important.
Yeah, and we can also say that there are harms that come out of healthcare, even though it may be applying a scientific. There's plenty of examples of that.
Yeah, and so that's another interesting polarity. There's the polarity um, of the very sad understanding that design innovation is move fast, break things mentality. That for me, that's like a tech bro mentality, and that is something that anyone who self respects in the design profession, especially in healthcare, uh, works really hard to avoid. Like I have no interest in breaking things. I create experiments in which things break and I observe them breaking, but always with a do no harm. And there's always like a harm reduction mentality especially in ethical design. Um, we have tremendous evidence that like move fast, break things like mentality has done tremendous harm. Look at social media. It was this like amazing way to connect the world, and now it's just a cesspool and like a tremendous like screaming to the void. And then there's the other extreme, which is the do no harm, do not experiment. Do like someone else has to do it 75 times before I even want to like look at it. That happens in healthcare, and when those two things come together, dangerous things can happen. And so we've seen a lot of healthcare startups, for example, pivot and abandon a population of people experiencing a specific type of a health condition, and also let clinicians that took the risk to adopt that product, that service, that device. And so that's a classic example of like how both ends, both like fringes need to meet at a healthy middle. you
Mm.
know
What's your sense of the big gap in healthcare in that polarity metrics? Like,
I mean,
it's the design side? Is it the
well, I mean, the good news is there's an appetite for design, and so of course, like that appetite uh, is where we live. Basically, we like the friction there happens when people who are trained to be incredibly risk averse understand that there needs to be new things, new ways, more integration, more person centric design. Uh, and so there's a little bit of like a a break there, because in my experience working in healthcare, no matter how like much these folks know that things need to be done differently, they are also trained to be terrified of a world where the thing that's been done for the last 10 years is done differently, and particularly don't see themselves at the center of a world where they are succeeding doing things differently. you know and so, like, for example, for a physician whose main tool uh, of of care are prescription medications, the idea of holistic care can be very scary. The idea of uh, moving past caring for the physical conditions and into like mental, or God forbid, spiritual conditions, um, as a consideration that the person's health is, many dimension. Um, that can be very scary. And so you see people who clearly understand very well and who are probably like uh, burning out because of that tension. And because of having to hold on to a system that does not allow for those complexities to exist, while understanding that those complexities are necessary.
mm.
I think it's very naive to think that uh, that the healthcare profession doesn't want things to change, or worse, that the healthcare profession doesn't understand the context nuances of the people that they care for.
Do you think it's a bit spellbound in the current way of its practice, or what's the source of the resistance, you think, to integrating a deeper, stronger
Well,
move
I
towards
mean,
holding those complexities, integrating a deeper sense of design? What is it?
Well, I think at the core of it is the fact that care has been taken out of everyday life. And
Mm,
so um, when you take care out of everyday life, you also take the caregivers, and you put them in these walled institutions and systems that have access gates, you know? And so um, there are very few places in the world where the doctor will still come to your home, and where you've had the same doctor since you were a child. Like those are things that are not so they're not so like foreign to people who are in their 60s right now, um, but have disappeared in the course of their lives. And so, of course, like the moment that you take the care person out of the context, and the moment that you add these efficiencies, okay, well, now that you don't go like house to house in your horse, now that you're in this like well lit hospital, well, you can see 15 patients today. um, and then of course the industrialization of the care visit, right? That's also like going back to what we were talking about earlier. Like the moment that you see that the average time that you need to prescribe a medication is 15 minutes, while you like observe, check, standardize the symptoms against a particular like diagnosis, and then apply the standardized treatment to that particular diagnosis, 50 minutes. And so, all right, well, then let's crank, like 5 minutes between visits, and here you go, like 25 patients today. And we hear some of the like very thoughtful and caring folks in our group having those days, and dragging an attending physician with them through a day like that also, And so that I think describes the complexity incredibly well. Like how are you going to like even conceive of a different system if you can be assigned 25 patients on any given day,
mm.
you know
Yeah, there seems to be a growing awareness that we stripped out care. We could also use the word, again, for some people might make them uncomfortable, the sacred out of
mm-hmm.
care. So it's the
Mm-hmm.
sense of the sacredness of life, right? I mean, healthcare seems to be the most healthcare, probably education, the most sacred spaces where we hold people's development, people's healing, people's suffering in the case of healthcare. Which, suffering seems to have been the bastion of spiritual traditions, religious traditions, trying to understand this human condition. But at the same time, I sense that there's more and more practitioners who are now feeling the grind of the loss of the sacred. Like they're feeling the grind of the loss of the care. As someone, for example, who worked in the caregiver space for a long time and continues to support that work, I could see how the caregiver's dilemma, speaking more on the family caregiver's dilemma, was that there was really no space for them in healthcare
Mm-hmm.
because there was no frame to hold the care. So, of course, they were undervalued. Of course, they were invisible because within the engineered system that you're talking about that had kind of lost its soul,
Mm-hmm.
family caregiving is soulful work. There's no question there's a technical side to it, but it's very much soulful work. Um,
And by the way, there are some efforts to try and like even bring the family caregivers into a compensation model, but we see it when we go out in the field time and time again. Unfortunately, when a loved one starts needing consistent care, it's typically the most underqualified person in the family that gets assigned to their care, the most underemployed, the most the person who typically is succeeding less at like having a very busy job and making a lot of money, and so uh, that is actually very reflective of that imbalance. Whereas we've spoken about this earlier, whereas if you put on a different lens, and you look, for example, at indigenous healthcare, like you see that whenever any member of the an indigenous community needs care, the community gathers and everybody gets care. And everybody gets care through ceremony that has both a medicinal aspect of, like, tried and true medicine, as well as a spiritual aspect of things that have worked for a very long time, even though we don't understand them very well. And so when you take off that lens, uh, it's very interesting that in North America, like, God is even baked into the Constitution, but there is no consideration for the spirituality of those that the state cares for, that the state should care for. And so that's another, like, place where the magic has been broken. A lot of powerful magic is powerful because it cannot be explained. It cannot be used in the context of a double-blind, peer-reviewed trial. Take psychedelics, for example. Like psychedelics are bound to being trialed with placebo, but it is very clear that no matter how much niacin you give, as a placebo, everybody who doesn't get the dose, who signed up for the trial because they very much need the dose, knows immediately that they got the placebo. And so, still, like, people are, like, patiently, like, doing that. But it just, like, it defies, and there's, what for some people might be a complete, like, woo-woo, like, there is an absolute, like, there's a tremendous body of scientific evidence as to how psychedelics create neuroplasticity, as to how, like, from a psychological standpoint, the dissolution of ego is incredibly useful, not just for creating, medication-resistant treatments to medication-resistant conditions, but also for, like, human development in general. And so that's yet another polarity: the fact that we've walled the care in places where you only go when you're very broken. You don't have access to that care, just because today is the day of care, which, by the way, is one of the reasons why a lot of religions hold weekly ceremony. Everybody needs a little care all the time. And so we've lost that in a lot of these weekly ceremonies, but that's also another interesting example of that polarity. And we see it all the time, by the way. Like, people ignore important early symptoms of the fact that today's life is killing them, because they discard them as part of, like, the necessary hustle to, like, live in the modern world. Oh, well, like, I'm sleeping poorly because I'm very stressed out, but that's just a job. Everybody, like, sleeps less as you get older. And I'm eating poorly because I eat my lunch at my desk, because there isn't a proper gathering place in my workplace, where we can actually, like, gather and share a meal, or because my deadlines are upon me, because this computer that in 1984 was announced as, like, a real, like, reduction in the amount of work that we have, has only increased the work that we each do every day tenfold. By the way, shout out to AI, which is about to, like, make me a design team of one, where before I needed 3 other minds that I could interact with, and that I could pressure test my assumptions with, in order to design anything. I'm very hopeful because it empowers me to do incredible things, but we can't have nice things. And so, like, that's, we don't create, I think Elon was saying that, we are going to be, like, rid of all work, and we are just going to be left to ponder our humanity in this new philosophical age of AI. And I think that is infantile, honestly. We're not going to be doing that, you know. So yeah, that's, I think that gives us a little bit of a journey through where those things are not happening because we don't have that lens. We don't have that lens of care. We don't have that lens of, ceremony. We don't have that lens of empowering caregivers to like truly like have their to have it be their calling, other than like just going to the job.
Yeah. You and I have talked about the importance, and it's something that's growing in our work at the Commons, the importance of designing with a mutual view of interiority and exteriority.
For the designer too, right? That's actually something that you're always very adamant on. That the process of designing well should transform the designer. And I think we've also spoken about how the early evils of the .com era have shaped designers into ethical design, where I think I told you, like, if you went to a design conference in like 2013, it was all about like agile versus waterfall and cool interaction patterns and sticky UX, and then we very rapidly started discovering the externalities, the unseen consequences of all those things, and immediately, because of course there is an ingredient of empathy necessary to be a human-centered designer. You need to actually have some feel for the people that you serve as a designer. Immediately, like we had to jump into like the ethical considerations of design, in terms of like justice, equity, diversity, inclusion, and even regenerative design methodologies that don't create more garbage in the world. Like that was a transformation that is exemplary of this, how design transforms the practitioner. And yet, like we're still, even though we've been transformed, and even we've been transformed into having a duty of all those influences in the context, we're still excessively focused on building things that engineering can execute. And so we are not without that dependence on the solution is a series of touch points that flow beautifully through an experience that has some sort of like an emotional effect, typically reward on the user, because reward creates loyalty to the experience, right? And those touch points are typically either digital or physical, but they are not designed to transform the inner experience of the person. I mean, there's some examples that are remarkable. Like, for example, the fallacy that dating apps are that some dating apps brag that they're designed to be deleted. That they're designed to, like, for you to find your perfect match and then just abandon it. Like, I'm pretty sure no one says that at the shareholders call. I'm pretty sure it's about retention and growth. And so again, though there are some examples that where we're making strong considerations of like changing the people that we serve, not just rewarding them, but like truly changing them. But again, it's also because of a lot of these products have live in environments of funding that have an insatiable appetite for growing up, for like scale in size rather than scale in purpose. Their purpose, after all, does not increase the shareholders. Even if purpose is actually like one of the biggest attractors of loyalty, a lot of it is just virtue signaling. And so there is an opportunity. The good news is that there is a tremendous opportunity for ways to design the interior as well as the exterior experience of anything, really.
Yeah. Well, they're
particularly also in healthcare,
Yeah, and we know that, like, just ontologically, they're co-arising.
Mm-hmm.
You don't need a spiritual lens for that. You can use a quantum lens. You can use any other kind of lens to understand that our interior worlds and our exterior worlds are co-informed each other. And even though we might, through certain processes, think we can suppress one, like suppress interiors, they always express themselves. Uh,
Yeah.
and if you want to know how they're expressing themselves, just look at the exterior design. Um, I mean, if you were thinking about, from a designer's perspective, if you were thinking about a healthcare renaissance,
Hmm.
what would be like a few orienting principles that you think would be absolutely essential to invite that next, developmental leap, next evolution in the healthcare experience?
Well, again, like and this is more me being a futurist, which sounds like I have a crystal ball. I don't. I just have a bunch of tools that allow me to understand the amount of agency that we have to design the future, as well as as series of ethical lenses that allow me to understand what a preferable future should look like, so that we are actually designing the right thing, not just slowly iterating into something that people will buy. And so when I think of that, um, and I put together the pillars of health, um, and that's actually a very important thing. Like holistic health means using a number of important pillars. Like for example, there's some that are already recognized, even if they're not very impacted, like sleep or stress. Um, there's others that are not, like that don't have a big space in the spaces of healthcare, like spiritual or community, and the importance of the family caregivers. And so when I think of a perfect world, there is a lot of recovering some of the practices that we've lost over time of community, ceremony, like natural, like plant medicine, be it psychoactive or non-psychoactive. I think that's why we're seeing such a resurgence of mushrooms at the center of like plant medicine, because whether you're talking about powerful adaptogens like lion's mane or cordyceps, or you're talking about like powerful psychological medicine like psychoactive mushrooms. Like there is a very interesting ingredient there in the fact that mushrooms are accessible to everyone. So they also have a democratic aspect where, in my dreams, like everybody has a beautiful aquarium style, like, thing in their home that, using whatever technologies, knows exactly what mushrooms to grow so that the whole family gets care that keeps them healthy, and that, that like empowers them to live their best life, rather than the current state of healthcare, which is waiting until someone has an lack of balance in their physical health so powerful that they are impeded from living any life whatsoever, and they have to like get in bed and or stop doing the things that they enjoy doing or that they need to do even to survive. So again, there's that polarity, you know, uh, like needing less healthcare practitioners so that the healthcare practitioners can have more time for those who need them, by like bringing these pillars of health into the home from day one. Um, Sounds like an interesting middle ground in those, between those polarities that we are talking about. Like, that sounds like a win-win for everybody. That's actually something that the systems of care understand, but have a very hard time implementing with value-based care. That when you look at the journey of health of a person and you invest in that journey of health, um, the in the improvement in care also happens because doctors are in a place where they can live their calling better, and and dedicate more time to the context in which those who actually do reach them exist. So I know that that's, that like there's, again, like none of my answers are ever like simple, because the problems aren't simple, but I feel like there's a good balance between, like bringing powerful, like, health tools into the everyday life of people, um, and improving the quality of care, and and the care centers for those who still, like, have like, conditions that can be accidental, environmental, that can actually, like, that will actually stem from the fact that the pace of change in our world is accelerating, and so there are many more unexpected events that can impact our health than there used to be.
I get the sense that part of what you're saying is that, or a strong feature of that renaissance, is designing from a place of care. Like,
Yeah.
just as the original, like, you think about the first mover, maybe that's oversimplifying, but if you think about the first mover, is what if we designed healthcare from a place of care?
Mm-hmm.
It's interesting, the order of healthcare. Like, healthcare is taking a bit of a second seat to health. I don't know if that was
I mean,
subconscious programming, but
also, like, there is not a lot of health in healthcare. It's like sick care.
yeah,
And so we've spoken about that until our, like, faces fell off.
right.
But that's actually, like, I like to remind us every time I can that the future of health care is health, not sickness. That's actually like a basic. And so I appreciate that you just added, because I will say that, the future of healthcare is health care, both of which are quite absent from healthcare today.
Mm.
You know.
Yeah. Yeah, I think there's, for me, care is kind of like the supportive infrastructure of the kind of design that you're talking about. Um, like, when you spend some time moving into your own interior, you noticed a very strong caring instinct, or a
Mm-hmm.
caring world, a loving world. Um, and that seems to me to be a natural place from which to move, to kind of honor the sense of the sacredness of things. It's a sacred
Mm-hmm.
it's a sacred act to be in the presence of someone who's suffering. There's a certain sacredness about that.
Mm-hmm.
um I think you've alluded to some of the ways in which we've stripped out the sacredness of that, over engineered these experiences, which human experiences, completely different than car repair or clock repair.
Mm-hmm.
Though we seem to have leaned on all of those metaphors in healthcare, which is weird. I mean, it's just a weird. It's like we've analogized two completely different, um, two different aspects of life, and it feels a little bit like that. Like, when I go into the hospital, I feel more like a VW than I do an MS.
Right.
You know.
So that's just it. Like, the hospital experience is designed, like, to mimic the repair shop, right? And so there's stations for each. There's like the engine station, and then there's the, like, place where you change the wheels, and then there's and it has to do with the mechanization of care, with the fact that these machines and processes were introduced from a mechanical standpoint.
It
Um,
seems like the intention. So my sense is, when I talk to people about healthcare, is that the right intention is in place. It's the wrong metaphor.
mhm.
I don't meet a lot of healthcare professionals who say I could really give a shit about caring. Like,
Of course.
I can't think of a time I've ever heard that. Um, but the operating metaphor is that more mechanized view. The training
Mhm.
is that more mechanized view. Um, that to me is the inherent conflict. It's that
Right.
the metaphor doesn't align well with the deeper wantingness to care, and we're stuck in the metaphor. And we could talk about all the perverse incentives and reasons why we're stuck in that metaphor. It's similar to like conversations about the meta crisis, the planetary crisis.
Hmm.
The metaphors are out of sync with the actual ecology of things. And healthcare has that same challenge, the same friction between the mechanized metaphor, the procedural metaphor that is soulless, like breaking apart a forest into its parts and not understanding the ecology of a forest.
Right. That's a very good metaphor.
Yeah.
Um,
So each one of us is like part of a larger ecology of meaning. There's kind of the ecology of our own experience, and there's the larger ecology of our social experience, our environmental experience. Healthcare just has not understood a way to hold that. It does not.
well, I think it has lost its understanding of the way to hold that. And again, I think to it's important to understand that at the core of this enthusiastic adoption of the industrialization of the systems of care comes a problem of access, right? The moment that we turned, you know, small self-sufficient societies into mass societies, and so of course a consequence of imperialism and then colonialism, the moment that we are, one nation of 300 million people, you immediately have a problem of industrializing like the necessary services, including health.
Right.
And so, and of course we do that the way we've done that, since we started industrializing things, by like adding more machines to it, and so it's like planting metal trees and hoping that they'll do the job of an ecosystem, right? So yeah, that's another interesting complexity, um, and it's a complexity that comes from an appetite to do good, to like have everybody, like have access to good uh, care, the standards of which are unfortunately, not very human.
Yeah, that's the thing. It's like I really do think that the heart of the intention was a good one. I mean, we could talk about all the benefits of industrialization. There's many. Access to
Mm-hmm.
more access to clean water, more access to some basic necessities of life, not for everyone, but for more people. Um, but there's all these unintended side effects. It seems like healthcare just struggles with the side effects, like the kind of narrowness of not being able to understand that in architecting certain solutions, that there's all these unintended side effects that have a cascade of problems. Like when you industrialize the healthcare system, you forewent a whole bunch of essential things that human need to heal, and you brought up some of them, like community and communion and connection, um, and a sense of
And
agency.
purpose, yeah, an
Yeah,
agency,
yeah,
right? Yeah,
right,
yeah, yeah.
right.
These are all problems of scale, really. Like, like if I heard Dominic Ward from Atlassian, which is, interestingly a software company, say something about scale that stuck with me, and it's that scale is doing less while having more impact. And so, from a software engineering standpoint, that is a tenet that translates very well. And so, as humans, we have a problem of scale in the sense that the moment that we're managing any system where we're not in full visibility of all the actors and processes, like we start creating negative externalities. Like I'm going to tell you, like through my work at Bayer, like the first thing, and I'm sure you've seen this every time you work with a pharma or with a large healthcare corporation, there is no such thing as evil pharma. There is just disconnected purpose and goals within an organization that's too large to do good.
Mm,
Of course, like everybody, like I've, like you see these conflicts in like plain sight. Like for example, here in the United States, payers are definitely like, motivated and get excited when they talk about preventive care. But the realities of preventive care is that one, they're bound to quarterly results because they are financial institutions. And two, they know that because people in the United States get their care from their employers for the most part, and this is why it baffles me that anybody would fight universal health care, but like because people typically get their healthcare from their employers and people change jobs, like they understand that the investment I am making on the preventive care of someone is benefit for one of my competitors 3 years down the line, because the average stay for someone with a healthcare plan is 3.5 years, 3.7 years, I think. And so those are unsurmountables. If I'm doing my job well, I am bringing quarterly profits. And if I'm doing my job well, I'm not spending in something that my competitor is going to benefit from. So that's an example of why like scale is bad for humans, you know?
Yeah. Yeah, it's a lot to digest. I mean, I think I see a lot of talk in healthcare where I get the sense that uh, people are maybe struggling to take the time to see both sides of the solution. What does this create? What does this uncreate? It sounds like in healthcare that anything we create that fixes something is good.
Mm-hmm.
Um, and I want to say that it's intentionally good, but it may
Mm-hmm.
not always be creating a larger good. Just like the idea, well, if we see more patients in a day, that will be good.
Mm-hmm.
Sounds right to your mind at first. If it's like more people getting help, that seems good.
Right, exactly.
There's
A lot of people need help, so let's make a system in which many people get help every day.
right. And we forget that, wait a second, like in those kinds of systems, we may also have like serious losses of agency, or
Mm-hmm.
we create the effect of so much demand that by virtue of that, we force a supply, like psychologically, that people feel like I'll break, someone will be there to fix. And again,
Mm-hmm.
that's not blame. It's just it's a psychology of also there's a psychology of disempowerment in that as well. Uh,
Mm-hmm.
there's just the kind of the same problem of the endless more. There's always just more of something available to me.
Mm-hmm.
So
Right.
it's subtle in some instances, and some it's more overt. Examples of we've talked about, introducing insects into certain ecologies who then create a whole other cascade of problems. Like they solve one issue and then create a whole other set of issues. And I can attest to that by having a house filled with Asian beetles every fall. Because someone thought, well, they'll solve a problem in farm fields, but it created a whole other slew of problems.
Yeah.
Um, and that's also a reason why I think we need a certain quality of wisdom um, to nurture and cultivate a certain quality of wisdom in healthcare. And I think the wisdom is to be both engineers and designers, to be both health practitioners and care practitioners. To elevate to
or
elevate
to
those polarities.
to be that, so that we can co-create with the other side better. And so I think the secret sauce there is that this is not something that I've invented, but this is one of the most powerful realizations that I've had in regards to co-creation. Co-creation is very easy to talk about, but it requires a vulnerability that begins in understanding and even experiencing the context for which you are co-creating, and also like at its simplest form, like being able to do 1/3 of the job of the person that you're collaborating with, at least, so that they can actually then go ahead and like do 1/3 of your job, whatever that job is. And so in that sense, I do agree that we have to be both designers and engineers, both like like cared and caring and cared. um and yes, I think I would add, like, and we need to be community. We need to like do this together, you
Right.
know and we need to do it. Of course, this is also a classic like design thinking, like thing that stands very well. We need to design with the people that we serve. rather than for, you know, uh, which is again, another bad effect of the patriarchy. Like, there's this patriarchal approach to doing things in patriarchies that is like, I will care for, rather than care with.